here, because there is not enough area within the bone, it can be more central, just to make the same point. One thing on MR, I don't think so anybody is going to show you an MR of GCT. As far as I know, it has never come in the exam. But one take-home point, maybe for your day-to-day radiology about MR of GCT, is that GCT has got some hemosiderin. And hemosiderin can be low signal, or not can be, it is low signal on T2. So the take-home point is that low T2 on GCTs can be seen. I don't think so. It's an exam thing. This is a GCT in short bones, carpal bones, tarsal bones. Please remember that because we are always taught these tumors on long bones, we tend to forget the short bones of the hands and feet. And all of these lesions, whatever can happen in long bone can also happen in these bones. So if you have got something like this, you remember in the previous chapter we did enchondromas. So with enchondromas, you can have giant cell tumor, as this example tells you. You can have simple bone cyst, you can have osteoid osteomas, you can have aneurysmal bone cyst, you can have brown tumors, you can have fibrous dysplasia. All of these things can occur. So keep your minds open, and the differential diagnosis will be on those other parameters like age and other associated things which you know. Candidate 4, your case.
So I've got a frontal and oblique radiographs of the hand in a 71-year-old female, in which I can see that there is arthropathy affecting the metacarpophalangeal joints predominantly, but in addition to that, and also the carpal bones, but there is a well-defined lucent lesions in the distal epiphysis of the radius, which has a sclerotic margin and has no surrounding periosteal reaction, no soft tissue mass, so it has a narrow zone of transition. So my differentials for this epiphyseal location and a benign lesion would include, again, I'd include GCT, but looking at the history of chronic wrist pain, I'm also thinking whether this could be an underlying geode, which can happen in degenerative.
Other than the parameters, very good, other than the parameters which you have described, radiologically speaking, anything which in this case is slightly atypical for a giant cell tumor.
The age is the biggest.
Okay, age is one. Anything else, radiologically speaking?
It is eccentric, but it
is eccentric.
It is abutting the articular surface as well.
Anything else? Can I? Okay, fine. Giant cell tumor. Look at notes. Non-sclerotic margin. Right? Classical giant cell tumor will have a margin which is non-sclerotic. And in your case, there is a bit of sclerosis. Right?
Yep.
So that is another parameter. You see, all of these, if you are an examiner, you remember that each case in the Viva carries between 4 and 8 marks. You have to get 6 marks to pass. Now, as an examiner, how will I give 6.5 versus 7 versus 7.5? So all of these things, if you pick it up, I might give you half a mark more, though your diagnosis remain correct. So these are very important, the fine touch. And the strategy in Viva is that you plan for more marks so that you can compensate anything which you should aim for better marks so that you can compensate for any case in which you did not do well and your marks are less than 6, 5.5 or 5, and you can compensate with a 7 in another film. This is your last film, please.
So I've got a frontal radiograph of the wrist of a skeletally immature patient in which I can see a lucent lesion in the distal metadiaphyseal region of the radius, which has a sclerotic margin and has some internal calcification. There's no cortical breach and no surrounding soft tissue mass. It has a narrow zone of transition and it is a single lesion. So my differentials would include so because of so it's a benign lesion, my differentials would include a simple bone cyst, but it's not entirely intramedullary. Thinking whether it could be an intraosseous lipoma because of the fact that I can see a calcification which looks like a fallen fragment to me, but it's not the most common location here.
So go back to your diagram, you know that diagram which I showed you?
Yeah.
What comes to your mind? Eccentric, metaphyseal?
Eccentric also include non-ossifying fibromas and...
Non-ossifying fibroma classically will not go till the epiphysis. They will be more metadiaphyseal or diaphyseal even. This is a aneurysmal bone cyst, but it is not aneurysmally dilated till now.
Okay.
And that is why your mind did not go into it. But location-wise, you know, that diagram, which I told you my favorite diagram, you know, it is given there, right? And this is what it is. This is and it is extra. Your thinking was absolutely spot on because you were thinking it's not central and things like that. But the only thing because of which you were confused is that it was not very expansile. So intentionally, I showed you this case, but you are right that it should be usually it's expansile, it should be bubbly, may occur secondary to some other lesion. Now, if you see all of these examples, and now here, something is here, this is it, this one looks more central, but then on the other view, it looks slightly eccentric. And as I was telling you, that always the same lesions can be in the short bones. So remember that aneurysmal bone cyst in the MR, and MR will show you fluid levels. So actually, I'll give you another case for a specific purpose. This is another aneurysmal bone cyst, and this one has got a fracture. Why is it aneurysmal bone cyst? Because it is eccentric. It is not central. Otherwise, a simple bone cyst will be top differential. And then there is a fallen fragment sign. Please remember that fallen fragment sign is not pathognomic for simple bone cyst. Some people think like that. No, it is not. It can happen in other conditions, and aneurysmal bone cyst is one of the examples. This is another case where we pick up multiple fluid levels, and means we clinch the diagnosis. And in your book is a differential diagnosis. Fluid levels in bone, in CT and MR, these are the lesions, benign, malignant. Aneurysmal bone cyst, chondroblastoma, giant cell tumor. Oh, sorry, there is a typo here. Now, what you should be worried about is this thing, telangiectatic osteosarcoma. I'll come back to this point, and this is your last film, and then number 5 should be ready after you. Over to you. This is a very good case. Over to you.
So I've got a frontal and lateral radiographs of the ankle in a skeletally immature patient in which I can see there is an expansile lucent lesion in the distal metadiaphyseal region, and there is soft tissue swelling, and There is also a periosteal reaction. Almost looks like the periosteum has been lifted up. The internal matrix of the lesion is not osteoid or chondroid, but the features associated are quite that of an aggressive lesion, so it has a wide zone of transition, I'd say. My differentials in a child of this age would include an Ewing's, that also include lymphoma, even though the bone matrix does not look as permeative here, but I'd consider an aggressive bone lesion here.
Okay, I am happy with your thinking of an aggressive lesion, so I'm very happy with that. But why Ewing's and why lymphoma? It is a cystic lesion, isn't it?
Yeah, just thinking about because it's quite aggressive, and I was thinking what aggressive lesions would I expect for someone that age. It isn't osteoid, which makes me think it's less likely to be an osteosarcoma.
So can I just take your attention back to, let's say, any of these cases, right? For example, your case looks like this or looks like this, but then there are aggressive features which you have picked up beautifully. Yeah. So what is this? These are the red flags. Okay, I'll take over, and well done. You can please mute yourself. Aneurysmal bone cyst versus telangiectatic osteosarcoma, you have to worry about this thing. So you go back to this differential. There are benign lesions which have got fluid levels, and a telangiectatic osteosarcoma can also have fluid levels. Telangiectatic osteosarcoma has basically got, it will be a cystic lesion with, you can confuse it with aneurysmal bone cyst. I've seen in my career 2 medical legal cases like this where we mixed it up, and in just 2 weeks down the road, it just blew up. So the key thing is that literature will tell you that plain film is very important. Look at the margin of the lesion and go back to your basics. Whenever you see an aneurysmal bone cyst, look at the margin of the lesion. At some points, the margin of the lesion will have a narrow zone of transition. But if there is a wide zone of transition in a portion of the lesion, or things like periosteal reaction, as in your case, think telangiectatic osteosarcoma, and advise an MR. I don't have the MR of this case, but this was confirmed, telangiectatic osteosarcoma. This is from literature. It tells you in telangiectatic osteosarcoma, you can again get a lot of fluid levels, but there is some soft tissue. In Royal National Orthopedic Hospital, what they do is that they have got some criteria to diagnose an aneurysmal bone cyst on MR. More than 75% of the lesion must have fluid levels. And if they are worried about any solid component, they target it with a biopsy to rule out telangiectatic osteosarcoma. But in a 2B world, the case which will come to your exam, in your exam, will be a plain film. And here you have to raise that issue, that I'm worried that it looks like a bubbly lesion, but it has got some aggressive features. Here is an aneurysmal bone cyst, complete 100% fluid levels. We are not worried. Okay, candidate 5. Can you raise your hand, please? Over to you. This film is poor quality. I will show you a bigger version. Just concentrate on this one, and then I'll show you a lateral, which will be better.
So it's a APN lateral plain X-ray of ankle of a 13-year-old patient, which is demonstrating lucent lesion in the dome of talus on the medial aspect with narrow zone of transition. There's no surrounding associated
Concentrate on this one. Well done. Please carry on.
There's no surrounding periosteal reaction. There is some pixelated, I mean, it's a zoom view, but it appears that soft tissue is slightly hazy, just adjacent to this lesion. There's no fracture through it. And there's a single lucent lesion with the benign features in the dome of the talus on the medial aspect in a 13-year-old patient. My differential in this patient would be simple bone cyst. It could be a Langer eosinophilic granuloma because there's no, it's a single lucent lesion. And so the differential could be a brown tumor, but there's no associated features of the brown tumor there. So,
okay, what is this where I'm pointing out?
There is some further kind of scalloping scalloping of the cortex there, and then there's some adjacent soft tissue swelling or
so can it be a bubbly lesion which has gone out?
Yeah, it can be a bubbly lesion which has gone out. Just like, for instance, aneurysmal bone cyst.
So what comes to your mind then? If this is an aneurysmal bone cyst, then what will this be?
If it's an aneurysmal bone cyst, this could be...
Let me ask you a theoretical question. What is your concept of secondary ABC? So these are ABC which actually arise within another tumor.
Yeah. So secondary ABCs are, as you mentioned, they arise in the previous tumors. For example, osteosarcoma or even GCT, they can arise within them. In a patient with this age, this is a most likely epiphyseal kind of lesion, single lucent lesion. So ABCs arising from that pre-existing lytic lesion in the dome of the talus. So I'm just trying to struggle to find out what this primary lesion could be in the dome of the talus, and then from there ABCs arising.
Okay, that's fine. I'll take over.
It's because of benign appearance because of narrow zone of transition.
Okay, thank you. Now, basically, if you remember this differential, you can get your answer. If you know this list, you can actually answer this question. And this is why I say that Chapman, or this is actually not given in Chapman, but the differential should be, this concept should be with you. Secondary ABCs, these are the tumors: GCT, chondroblastoma, osteoblastoma, fibrous dysplasia, and non-ossifying, and as well as trauma. This is controversial. Some people think that trauma can cause it, post-trauma, but other things they do not. There is another differential diagnosis here. Where do you see this? This is what I was talking about, location-specific lesions. One of them was osteoblastoma, and it is written in your Chapman. And, sometimes two words in Chapman, can pass or fail your exam. And this is very important, osteoblastoma talus. So once you know it, come back to this lesion. This is a lucent lesion, which is subarticular, 13-year-old. It can be either a chondroblastoma or a osteoblastoma. In this particular case, it was a osteoblastoma. But in the exam, if you say either a chondro or osteo, I'll take both of them. And with that, it is an aneurysmal bone cyst. Aneurysmal bone cyst in the spine. In the earlier section, we did lot of lesions in the posterior, osteoblastoma, and we did consider that the differential diagnosis will be an aneurysmal bone cyst. And look at this lesion, which is so much fluid levels, 7-year-old with aneurysmal bone cyst. This is a beautiful case. I will show you a bigger picture once you describe it. All of you should concentrate on this. This has come in the exam and it's a very, very good case.
So it's a 14-year-old patient with a tibia and fibula, AP and lateral, which is having pain and swelling. So on the frontal view, I can see the fibular diaphysis has got an irregular cortices on the lateral side.
Because you have picked up, I have given you a blow-up. Over to you.
So there is a kind of permeative appearance to that segment of the fibula with cortical irregularity. And there's also some soft, if I compare the soft tissue density of the surrounding leg or distal leg, there may be a bit of soft tissue component, but it's very hard to say on this projection. But this is a aggressive lesion in the diaphysis of the fibula with cortical irregularity.
Anything else in the soft tissues?
Soft tissue looks a bit dense to me. There's no ossification. There's no mineralization of the. There could be just proximally. There's a focus of soft tissue calcification or ossification there. Just a single, I would say, focus.
What will you do next?
So this looks like Ewing's to me, but yeah, I would do an MRI of the patient. And
here you are. Let me guide you. These are stir sequences. This is T1 non-fat saturated pre-contrast. This is with contrast. And similarly, this is T1 non-fat saturated without. And this is a stir and this is with contrast. So over to you.
So MRI with T1 non-fat sat stir and the post-contrast is demonstrating a high signal intensity in T1 stir, and then there are areas of enhancement in the soft tissue post-contrast surrounding the lesion in the diaphysis, mid-diaphysis of the fibula, which has lost its cortex. There is also a bit of periosteal reaction around the fibula. These are highly concerning feature for aggressive tumor, for example, Ewing in this patient. I would refer the patient urgently to regional sarcoma MDT.
Okay, I'll take over. Now going back, if you see, you picked up very well that there is a permeative bony destruction in the mid. The key finding, you picked it up, but you cannot correlate this. These are phleboletes. These are classical phleboletes. And then on this MR, this is a classical appearance of intramuscular hemangioma, which has got high stir, it has got some high signal on this pre-contrast T1, enhancement on post-contrast. If you concentrate on here, you see this this bit. This is that fibula where it is going in. So it will cross into the bone. It is causing permeative type of destruction, but actually it's a benign lesion. And if you look carefully, there might be some fluid levels. For this case, the key finding was to pick up this. And Ewing's will never behave like this. You see, it is sitting far away. This is the fibula where the lesion is sitting. And it's very classical for a intramuscular hemangioma. And intramuscular hemangiomas, classically, another viva question is, how can you confirm it? And what they do is in RNOH that they do a Doppler. And, this is very compressible lesion, and that is also considered diagnostic. So intramuscular hemangiomas, this is, just to make the same point that phleboletes, you have to look for phleboletes. Okay, over to you. Give me the diagnosis here, just the diagnosis, please.
It's a vertebral hemangioma. It's a
Excellent.
corduroy type appearance.
Excellent. So this is the what we call the corduroy sign. This is the trouser of hemangioma of the vertebral body. Vertebral hemangiomas are very commonly seen in spine MR. Classically, they will be high signal on T1 as well as T2 weighted sequence. If it is high signal on T1, don't worry then. I'm not going into the world of atypical hemangiomas, which has got many gray areas, and I don't think so that's for FRCR 2B. That's beyond. So anything high signal on T1 as well as T2, it's a good news. Yes, please.
It's a skull X-ray of a skeletally mature patient, which is demonstrating lucent lesion with calcification or trabeculation within it in a very geographical pattern. There are also some focal phleboliths or densities within them, and I'm just wondering whether it's another example of hemangioma in the skull.
Right. So the description is that the hemangioma of the skull will have two types of appearance. It's a pathognomic finding, where it can have what we call a honeycomb or this kind of a sunray type of appearance. So these are multiple examples. This is case one. This is an example from Radiopedia on a CT, beautiful case. And this is another example. And then on MR, there will be enhancement. The hemangiomas, they sit within the diploic space. And the point of discussion here is that in your C and S in the Chapman, there is a differential diagnosis for skull wall lucency with sclerotic edge, and second one is skull wall lucency. One is with and another one is without. So hemangioma is given without, and it is not given with sclerotic edge. And I think you have to add that it can happen in both of them. Even our case here, you can see a bit of sclerosis here. You can see a bit of sclerosis. There will be other cases in which you will not find sclerosis. So another case for you.
It's a 45-year-old patient with a skull X-ray frontal view, which is demonstrating a lucent, relatively ill-defined lucent lesion with a bit of permeative appearance on the left frontoparietal aspect. This has got a bit of focal density within it. Also, again, there is a trabecular pattern within it. My differential here in this age group, hemangioma is number one differential. Other differential could be a metastatic lesion from a known unknown primary, although unlikely. Patient is relatively young. These are my top two differential.
Okay, if you see here, there is a lesion here, and the same lesion is projected on this lateral, and there is a bit of marginal sclerosis. Now, what will be your diagnosis or differential?
So it's quite well-defined lesion with the marginal sclerosis. That means the
pattern.
Sorry?
What is the pattern of, the internal lucencies and look at
honeycomb kind of pattern.
So what is your differential then?
Hemangioma is my top differential here.
And what else?
It's a slow ongoing process, sclerotic. So I can't think of any other explanation. Of
Excellent. So this is what I was. At times the examiners will grill you, and you have to hold your confidence. When a lesion is pathognomic, means classical, and there is no differential, don't change your opinion, and this is what you did not change your opinion, so that's perfect. That this is a hemangioma, and this hemangioma has got that honeycomb appearance. And the point is that a metastasis or anything will not look like this. So this was my point. Skull wall lucency with sclerotic edge. In this differential, add hemangioma. And skull wall lucency without sclerotic edge, hemangioma is already given in your book. So if you can add this. I will cover this again in CNS. The skull I'll cover in CNS.
So,
yes, please.
It's a thumb DP radiograph, it's a digit of thumb, which is demonstrating an eccentric lucent lesion with sclerotic margin in the tuft, with a bit of fragment within it.
There is nothing inside, so don't worry about it.
Okay. There's a breach of cortex here as well, so there's a fracture through it as well.
Breach of cortex, okay, this was artifactual. There is no breach.
Okay. So it's an eccentric lucent lesion with a sclerotic margin in the tuft of the phalanx, in the tuft of the finger or digit. Its appearance of benign, and again, differential here could be aneurysmal bone cyst could be there, a hemangioma, glomus tumor can sometimes give this appearance. I would be guided by the history of the patient as well, but these are my top three differentials, and this is a benign lucent lesion.
Okay, I'll take over. Hemangiomas, hemangiomas will not give you this kind of radiology in the distal phalanx. Your top differential has to be, this is your differential, lytic lesions in the phalanx, poorly defined, well defined. And we are in this world here, it's well defined. And well defined is enchondroma. Of course, this will be secondary to some joint abnormality. Implantation epidermoid should be up there. And then glomus, tumor, and sarcoidosis, and other rare lesion not specific to the phalanges. These are very important. You see, this is the same concept which I was talking about in, fibrous dysplasia, ABC, giant cell tumor, simple bone cyst, brown tumor, LCH, fibrous cortical defect. All of these things can occur. This is a case which I have already shown you in the first chapter, where this is a lytic phase of fibrous dysplasia and there is ground glass. This is very important exam case. So all of these things can happen. But this particular case is an implantation dermoid. Implantation dermoid, what happens is that this is post-trauma. So maybe a thorn injury or something. So part of the skin, it goes in and it starts growing. And when it starts growing because it is stratified squamous epithelium, and it is meant to grow with time. So this is the same concept as epidermoid in the skull wall or a cholesteatoma in the temporal bone. Please remember that a cholesteatoma in the temporal bone is the same thing as an epidermoid. When it happens in the temporal bone, we call it a cholesteatoma. Pathologically speaking, it's the same. And key point is that these lesions show restricted diffusion. So if I don't have a diffusion weighted scan for this, but if I had, this lesion will show restricted diffusion. Just to make a point, I'm showing you an epidermoid of the skull, which per se is a exam case. Usually epidermoid of the skull will have a sclerotic, it will be a lytic with a lesion with sclerotic margin, and it is showing restricted diffusion. So, okay, this is your last case.
Okay. It's a 47-year-old female, DPV of a digit of the hand, which is demonstrating an eccentric lucent lesion in the distal phalanx without any soft tissue component or periosteal reaction. It has got narrow zone of transition. There's a bit of sclerosis around the lesion, which is kind of end scalloping or slow growing process which demonstrate. It appearance are benign, and considering the age and location of the lesion, my differential here would be glomus tumor, epidermoid cyst or lesion. Other differential could be, I mean, it's highly unlikely to be enchondroma. There's no expansile lesion here.
So out of glomus tumor, what says an implantation epidermoid, what it is?
Glomus tumor is my.
Why?
It's showing a bit of scalloping, and there's a sclerosis around the lesion.
Okay, well done. Okay, we stop here. You can mute yourself. Now, glomus tumor is also known as a hemangioma. It's a very vascular lesion, and it occurs under the nail. This is what it is. Look at this picture. It causes scalloping. It is very painful. It will be blue, clinically speaking, and very painful. And it will cause scalloping. This scalloping is on the dorsal surface of the phalanx, like this. And this is the case which we were seeing. On an MR, it will be high signal on T2. It can enhance, etc. But the key thing is that it's not sitting inside the bone. It is sitting outside and is causing scalloping of the dorsal surface. On the other hand, the implantation dermoid will be on the palmar surface, and it will be totally a lesion which has got marginal scale because it is within the bone. That one was causing scalloping. This is the difference. Candidate 6. We have to finish in about 15 minutes, so a few cases to go. Now, candidate 6, can you raise your hand if you are with us? Candidate 6, can you raise your hand if you are not okay? So candidate 2 or 3, if you can raise your hand. So I've got quite a few hands, and let's see if I can see 6 there. 6, unfortunately, is not there. So I will give few cases to 2 and then a few cases to 3. So 3, you also be ready. Number 2, please.
Yes. So this is an AP radiograph of the left humerus of a 6-year-old male patient. There is a lytic lesion within the proximal aspect of the humeral metadiaphysis, which is mildly expansile. It occupies most of the bone, appears to be essentially centrally located. There's some cortical thinning, although no obvious cortical destruction. And it has a somewhat multilobular location with some thin internal septations. My primary diagnosis is a benign lesion, most likely an aneurysmal bone cyst.
And why do you say an aneurysmal bone cyst?
Due to the expansion and the septi.
What is the location of the lesion?
It's somewhat...
The diagram. Go back to the diagram. Is it central? Is it eccentric?
It's quite central.
Okay, so can you reconsider that?
It could be a simple bone cyst.
Here you are. So simple bone cyst, number 1, because of the reason which I have told you, and it is more central. Please remember that there is a concept of what we call migration of cyst. So what happens is that in simple bone cyst, the cyst will be at a metaphysis, and it as the kid grows, the bone might the lesion might shift into the diaphysis. So this is a simple bone cyst. In differential, you can consider aneurysmal and then tell the examiner you're thinking, because it is central, it is in keeping with a simple bone cyst. And so 5 to 20 is the age. This is a simple bone cyst with a fallen fragment sign, nothing, another simple bone cyst with a fallen fragment sign. Okay, this is, you remember that I told you that in your book, lesion specified calcaneum. In talus osteoblastoma, in calcaneum lipoma was given, and a simple bone cyst was given. So this is a simple bone cyst in the calcaneum. Here you are. Intraosseous lipoma, calcaneum, simple bone cyst, calcaneum, osteoblastoma, talus. All of these are exam cases. And again, my emphasis: do not forget the same pathologies in the short bones. And this one is quite, bubbly, but it ultimately proved to be a simple bone cyst. Okay, anything in the soft tissues?
Yeah, there's fairly poorly defined area of what looks like increased translucency in soft tissues around the mid-diaphysis of the left femur.
So you have picked up this thing, and so what is the conclusion?
So because it seems to be increasing the transmission of the X-rays, it must be less dense than normal soft tissue, so potentially either a large cyst or a lipoma. Oh no, sorry, just a lipoma.
Lipoma, it's low density, means it has to be less than soft tissue. So on an MR, this was confirmed. If you see here, and it saturates here. Can you tackle this as a film?
The lateral radiograph of a right calcaneus vascularly mature patient. There's a well-defined lytic lesion in the anterior part of the bone.
I stop you because of time factor. What will you do next?
So it looks benign. My primary differential is between a calcaneal lipoma or a simple bone cyst. If there are some small calcifications within which favors lipoma, but if I wish to prove it, a CT could demonstrate the density of the lesion.
Oh, as a matter of principle, keep yourself to MR, right? You see, in the 2B world, just osteoid osteoma is CT, otherwise MR. And in the real world also, this is what we do. And this is an MR. What is your diagnosis? Just give me the diagnosis. Compare this with this.
It's a lipoma.
Lipoma. In the lipoma, there might be a central calcification which occurs low signal here. Now, please remember that calcaneal lesions per se has got a differential diagnosis according to the age it changes. So we have already covered, lipoma, simple bone cyst, giant cell tumor, and then hemophilic pseudotumor, brown tumor. All of these can come in the differential diagnosis. Hemophilic pseudotumor in the calcaneum has come in the exam. It's quite a favorite site. I'll show you next time. Yes, please.
So these are AP and lateral radiographs of the left humerus of a 62-year-old female patient. I'm told there's a long-standing swelling in the arm. In keeping with this, there's an abnormality of the soft tissues around the proximal to mid-diaphysis of the humerus, which contains some calcifications within, although is mostly of low density.
Okay, what will you do next?
An MRI.
Here you are.
Okay, so on the MR we've got axial T1 and stir. And coronal, we've got another stir. So there's a well-circumscribed lesion, which is high in signal intensity on T1 and low on the inversion recovery sequences. So that suggests fat because it's inverted. It's the same signal as the subcutaneous fat, within which there are areas of low signal intensity, which probably represent the calcifications that we saw on the X-ray. I think this is also a lipoma. If there's pain, I would just be considerous of sarcomatous transformation.
Okay, you stop here. You stop here, rather. I'll take over. The point is that, you see, this is a fatty lesion. Within the fatty lesion, you can see some solid component. And the solid component actually on post-contrast also enhances. So this is a liposarcoma. Now go back to the basics and see there is calcification or in the soft tissue. And in your book, there is a differential soft tissue ossification. And in liposarcomas, it can happen. So liposarcoma per se has come in the exam, and the basic concept is it's a huge subject in radiology, which is beyond 2B. So don't overload yourself. The point to remember is that lipoma, there can be what we call well-differentiated liposarcomas versus undifferentiated or myxoid liposarcomas. Key point is that if a lesion is fatty and completely suppresses the lesion like this, you see, this has completely suppressed. We are happy that this is a lipoma, and we stop here. Some people think a size criteria of more than 5, they give some weightage, but we can stop as far as the malignant features are concerned. On the other hand, look inside the lesion. If the lesion has got septi like this, look at this. Thick septi more than 2 millimeter, you should be worried. If there is globular or nodular non-adipose tissue, like this case, you should be worried. And if the fatty component is less, you should be worried. Size greater than 10 centimeter, you should be worried. So then it is a malignant transformation. And if you see a lesion like this, you can do a biopsy because it gives you a target. But if a lesion is well differentiated and it contains only a 2 millimeter, or 3 millimeter thickness of septi, you cannot do a biopsy. You just remove the lesion. To do a biopsy here, though radiologically speaking, it looks like malignant, but we can do a biopsy. We will do a biopsy. Why? Confirm the diagnosis, and it will help plan the surgery. It will require a larger, excision of the margins, etc. So these are a few concepts, but in a FRCR exam, liposarcoma has come in the exam, and you should think like this, that within the lipoma, if I find any soft tissue, if I find thick septi, I will raise the issue. Okay, last few films are left, and all of these are, except for one odd, are for classical 2B films and for observation. So this is over to you.
So this is a frontal chest radiograph of an adult patient. I don't see any acute focal lung lesion. So going through review areas. saying abnormality is not striking. There looks to be some cortical thickening of the inferior cortex of one of the ribs on the right. I think that's the
Excellent. More ribs?
right rib.
Okay, conclusion.
There's an area of well-defined periosteal reaction in the right rib of an adult patient.
Here? Or here?
Yeah. Oh, okay, so it's multiple ribs then. So in an adult, my first concern would be metastases.
Actually, this is not a periosteal reaction. Maybe for you it is projecting like that. So let me guide you. There is no periosteal reaction. What is your conclusion with these ribs?
And they look actually quite widely spaced compared to the adjacent ribs either side.
Very good. Very good.
I think there might be a sort of chest wall mass that's splaying the ribs and causing some reactive sclerosis.
So I am going into a differential diagnosis from your chest wall, which is classical for your exam. And this is what? Heading of the differential?
Rib splaying?
Inferior rib notching.
Oh, notching. Okay, yeah.
Classical, absolutely classical 2B film, where you can see that there is rib notching here, there is rib notching here. You picked up this thing very well. This kind of a finding you will only pick up when we go through your protocol and ultimately you pick it up. It's a subtle finding. And in this particular case, there was neurofibromas. This is a case of neurofibromatosis, neurogenic tumor. And the differential diagnosis, rib notching inferior surface. There is a differential diagnosis in your book, inferior surface and superior surface. So neurogenic is what we are talking about. This is your last case, and then number 3 should be ready. This is also a classical 2B film, absolute classical.
Again, a frontal chest radiograph of an adult patient. There's some atelectasis in the left lower zone, otherwise the lungs appear clear. I'm not sure it's projected very well for me, but I'm trying to assess the bones.
What is this?
There's some increased soft tissue over the right apex with what looks like possibly some ill-defined calcification within the region of the...
So don't worry about calcification. There is a soft tissue. Please continue.
Okay, so there's a soft tissue mass located in the region of the right apex that seems to be inferiorly displacing the pleural edge and causing some abnormality of the mediastinal contour in that region.
Is it in the anterior mediastinum? Is it in the posterior mediastinum? Where is it?
So I think the cervicothoracic sign is positive.
And what does that mean?
Well, that's the bit I can't remember.
Okay, well done. Okay, classical exam case where what happens is if you pick up a mass here. Now there is a widening of the paratracheal stripe, but more superior to the level of the clavicle, you see this mass. Now this is cervicothoracic sign. What is cervicothoracic sign? Basically, if you go back to your anatomy, superior to the level of the clavicle, the lung is quite narrow. So if a mass is anteriorly placed, there is no air anterior to the mass, and that mass will not be well defined. It will be ill-defined. On the other hand, if a mass is posteriorly placed, there will be lung anterior to that, and it is a sort of an extension of what we call the silhouette sign. So because of which the margin of the mass will be will be crisp and sharp. This is known as cervicothoracic sign, and this indirectly means that there is a posterior mediastinal mass. Classical exam film. So they will show you this. They will ask you cervicothoracic sign. They will ask the explanation. What will you do next? And the answer will be cross-sectional imaging. You remember the differential diagnosis, and one of them is neurogenic tumor. And this was a neurogenic, classical dumbbell-shaped tumor which was going out. So this is it. This is posterior mediastinal masses in adult, and also, in children will have nerve sheath tumors in differential. Okay, candidate number 3, can you raise your hand? Okay, over to you.
So, frontal and lateral radiographs of the tibia and fibula. There is a poorly defined central proximal metaphyseal lesion with surrounding sclerosis. The bone appears to have a slightly primitive pattern, and the zone of transition appears to be quite wide. On the lateral radiograph, there also appears to be some periosteal reaction. Overall,
conclusion. Your conclusion.
So
I'm cutting you because of the time factor.
Aggressive lesion, and I'm concerned with the fever about osteomyelitis, Brody's abscess, septic process. I would call it an MR.
Okay, I don't have an MR, but I just want to ask you differential. So you talked about aggressive process, absolutely fine. Infection, absolutely fine. What else?
So since it's
ESR, pain, fever.
Okay, so it can be a malignancy such as osteosarcoma or Ewing's, Langerhans cell histocytosis.
I stop you here. So the take-home point is, I've shown you MRs in infections also. MR is the correct answer. You will ask for an MR because MR can at times differentiate between the two, infection versus a tumor. Please also remember that the main differential is infection versus Ewing's. Ewing's is the king tumor. FRCR Ewing's, always consider Ewing up there, and it's very common also, relatively speaking, I mean to say. Also remember, clinically speaking, Ewing's and osteomyelitis at times cannot be differentiated, and it might have fever. The patient might have fever, glazed VCR, ESR, and pain, etc. So this was Ewing's, but the way you have tackled it is absolutely fine, and the differential is absolutely fine, 0 to 5 to 20. Now the cases which I am showing you, all of you, please concentrate. These are, I think 3 or 4 cases are left. These are just cases, and these are observation cases. Observation cases are cases in which once you pick up the findings, it's dusted. And so these are only left, and all of them are extremely good film. This particular film is very good, but this was from our hard copy collection, so we scanned it, so that's why the quality is poor. Having said that, it's a classical 2B film. Over to you.
So over the right midzone, there's increased density, and when you compare the soft tissues on the right compared to the left, there's increased soft tissue thickening.
Look at the ribs, please.
The ribs are also sclerosed, and there's increased density in the posterior ribs on the right. So I'm concerned.
Do you think this rib is normal, where I'm pointing out?
No, it's not normal. It appears to be expanded. It's clotic. It looks like it's infiltrated.
Do you look at this soft tissue versus this soft tissue, any difference?
Yes, on the right-hand side, the soft tissue is increased.
Your conclusion, what is your conclusion?
So I'm concerned about the chest wall lesion, a soft tissue sarcoma of the chest wall. Be my 2 top differentials.
What is the age of this patient?
So the epiphyses appear to be closed. They don't have much degenerative change. Probably a middle age.
Look at this one. Look at this one.
All right. Okay. So they're open. So in a child, I'll be concerned about metastases, such as a neuroblastoma. Metastases can present like this. It can also be Ewing sarcoma of the chest.
Okay. So you see, this is a classical exam case. The key thing is look at the age of the lesion. You know, it is at the edge of the film. We call it edge of the film, right? And then you pick up, there is something wrong, and initially you think there is consolidation. Look carefully, there is soft tissue thickening. And then you look at this destruction of the bone. So it's a chest wall lesion presenting like this. Classical differential will be the same. The top two will be infection versus Ewing's. So they have to be on top. You can keep eosinophilic, LCH, etc. in the differential, but those will remain. Another film which has got subtle findings. Over to you.
So in the proximal femur, there appears to be a periosteal reaction on the lateral aspect, and on the distal.
Yeah, so this thing is a fibrous cortical defect. You have picked up a periosteal reaction. Do you think this is a normal marrow here?
No,
Close up.
it's no, the marrow appears to be heterogeneous and slightly sclerotic.
What will you do next?
MR.
Okay, so this is another example. You know, if there is no periosteal reaction, it will be next to impossible on this resolution to pick it up. But if you look carefully, you know, this marrow is not normal. You remember the words which I showed you, moth-eaten versus permeative. And this marrow is abnormal. Of course, the main finding becomes easy because of periosteal reaction. On MR, it is horrendous. It is an Ewing sarcoma. Look at the bone. There is no normal marrow. Low T1 and high on the stir sequence. Last few cases are all observation films, classical 2B films. So please concentrate, develop your eyes on these. These are classical exam films, and these are all observational films. Over to candidate 3.
So in the left shoulder, there's a large soft tissue component surrounding the proximal humerus with abnormal medullary density. There also appears to be some scalloping of the lateral humerus. So in a 14-year-old, and in this region, I'll be concerned about a osteosarcoma, given the large soft tissue components.
And you will do an MR, right?
I'll do an MR.
Soft tissue components in a young child, most common tumor is Ewing's. Ewing's, you know, has got, classically speaking, big soft tissue component, right? So Ewing should be up there. In this age group, 14 years old, you have to keep it up. But I wanted to show you this plain film, and it's a good resolution film. Develop your eyes on this. Look at this. This is the cortex. This is the cortex. First of all, something is here, right? Then you look at the medullary cavity. Look at this medullary cavity. As we go in, look at this medullary cavity. There is something wrong. Even if you pick up that I am a bit worried and something is wrong, actually there is a bit of permeation, you know. Look at this pattern. It doesn't make sense. And with that, the soft tissue. So on MR, again, completely abnormal. And if you see, this is a T1 weighted sequence. And look at this soft tissue which is surrounding. Look at this soft tissue which is surrounding it. Look at this soft tissue. Classical for Ewing sarcoma. The differential will be lymphoma. Lymphoma can also cause a soft tissue like this, but usually not as thickened. Number 2, lymphomas in this age group with this kind of radiology are much rarer. Out of 100 cases, maybe 5 of them might be lymphomas. But radiologically speaking, yes, lymphoma can be kept in the differential with this fine print that the soft tissue might not be as much. So this is classical Ewing sarcoma, and this picture also tells you what happens. Another observation film, I think the second last of the day. Over to you.
So in the lateral iliac crest, there appears to be increased.
Which side?
Left side.
Okay.
The iliac crest. So in the iliac crest, compared to the contralateral side, there appears to be a periosteal reaction or cortical irregularity. There's also possibly some lucency within the iliac, in the medullary cavity within the ileum. The appearances overall are aggressive, and again, I'll be concerned about an aggressive process such as Ewing's osteosarcoma or infection, and would recommend an MRI.
Okay, very good. If you see this case, very subtle findings, and this is, you are expecting this kind of an observational film in the exam, where you see this cortex versus this, something is there, then you start challenging yourself, oh, something is happening there, compare it with this side, maybe there is something. And this was a Ewing's. If you read literature, Ewing's will tell literature will tell you that sometimes it's very difficult in Ewing's, or you can confuse an osseous matrix. You remember we were discussing osseous matrix in the previous chapter, and you can have a discussion in your mind, oh, is there osseous matrix? So the literature tells you that at times in Ewing's, the periosteal reaction is so exuberant that you can confuse it, and it will give you a bit of sclerosis like this. Having said that, it's fine. In the exam, it's fine. You've done your duty once you pick it up and ask for an MR, not a CT. But even on this CT, you can see this soft tissue, how thick it is. Actually, this is not the last case. So in this case, there are metastases. Now, all of you concentrate on this. And there are 3 metastases.
Okay, so there's one in the posterior left rib.
This is one. This is second.
Hello?
Yes, we are listening, please. Please. So I want you to pick up the third metastasis.
Okay,
Bone
so
metastasis.
Bone metastasis. So there appears to be, there's one in the left posterior rib, and there's one projected over the right scapula. And
No,
I think there's one.
Excuse me. This one and this one, I have myself told you, right? I want you to pick up, there is another one, and I want you to develop your eyes for the third one, classical exam one. Please, over to you. Where is the third metastasis?
Is it in the left scapula?
No. I'll give you 20 more seconds. Look at the spine. Let me give you a hint.
So in the lower scapula, I think it's around T12, there's an increased area of lucency.
Okay, I'll stop you because of the time factor. Please remember, these are the classical observational films. And in these types of film, right now I am rushing you, so don't worry because of the time factor. Otherwise, I would have given you the time to go through it. You go through your protocol, examiner has told you spine, so you start describing it in detail. Having said that, look at this. This is T1. You see the transverse process, this is T1. What is happening here? You see this destruction? And this is C7. And what is happening? There is a definite lesion sitting here. So this is the type of observational film for which you have to pick up, develop your eyes. And the key thing is to go through your protocol. You will never pick these things up initially. Start describing the X-ray. Never keep quiet. If you keep quiet, then your adrenaline will be released, and you will be so much under tension that all of your thought process goes down the drain. Keep describing. Number 2, if the examiner gives you a hint, go in details, and if the examiner says review the thorax, start describing, I'm looking at this, I'm looking at that, I'm looking at that. That should be your technique. Think aloud, and that will give you the leeway. And even if you don't get it, the examiner will give you some marks because you have gone through your scheme. This is a case of clavicle, periosteal reaction, and the differential will be Ewing's versus infection. This is a case of, again, an observational film in which this tumor was missed actually by us. And it became a sort of a complaint type of a case. If you see here, why I'm not giving it to you, because the resolution is not very good. By the way, candidate 3, have you picked up any finding?
In the humoral head, I think it's the medullary cavity is slightly primitive.
Okay, I will take over. You see, this is humerus is fine, this is fine, this is fine. Do you see this lucency in the acromion? Right? So I don't blame you because the resolution is poor, but on PACS it was very well visualized. And there is a lucency sitting there, and there was a huge tumor sitting there, absolutely huge. And these were some metastases. You see, it's completely destroyed, and we missed this. So this is a type of case which can come as an observational film. Last case of the day, and this is a beautiful film for the same reason. It's an observational film, classical 2B. 466 people are still with us. If all of you can concentrate on this.
So there appears to be increased density in the left paravertebral region behind the heart shadow.
This thing, I am not worried. Please continue.
So I'm looking at the remainder of the lungs. There's no consolidation or collapse. Incidental note of an azygos fissure. So I'm reviewing the bones. I can't see any abnormality in the clavicles or the proximal humera bilaterally. The glenohumeral joints appear to be preserved. Looking at the ribs, I can't see any destructive rib lesions. And looking at the spine posteriorly, there's a vertebra that appears to be slightly more lucent.
Don't worry. Look at the soft tissues, please.
So in the right, projected over the right clavicle, there's increased soft tissue swelling compared to the contralateral side. So it looks quite expanded. The actual bony clavicle doesn't appear to have any associated erosions. So this may be a soft tissue lesion of the right.
Anything happening to the scapula?
There's some lucency around the superior glenoids.
Angle, superior angle.
Yes, so the spine of the scapula, there appears to be an aggressive periosteal reaction on the right-hand side.
So this is a beautiful film for 2B and for observation. And if you see here, look at this soft tissue, and you can see normal fat plane here. And then you compare it with this, there is a definite finding. And there is no soft. And then you see this scapula, and this scapula versus this scapula. So there is something happening, a bit of permeation, expansion, or destruction, whatever. So once you pick it up, then you, I'm showing you a close, there's a bit of a technical problem in here, but just to make the point that this is that soft tissue, and here was that bony destruction. This is too easy, of course, but here it becomes a bit difficult. And on MR, you can see a lot of soft tissue. What is your conclusion with this MR? Soft tissue, so much soft tissue with the tumor.
So it could be a liposarcoma.
Why do you say liposarcoma?
There's a large soft tissue component. I suppose, given
large soft tissue components, Ewings, if the age, because Ewings can be up to 30 at times, and of course, lymphoma should be up there. Lymphoma, right? This was Ewings, and then, so this was, I believe, the last case of the day. And last few cases which I showed you were all observational films. If you pick it up, the key take-home point is, I'll just give you the final tip for the exam. In these cases, in observational films, you can mute yourself. Thank you very much, candidate 3. Last tip of the day is regarding observational films in the exam. And listen to this carefully. What will happen in the exam that there will be cases in which the findings will be subtle and you are never going to pick them up initially. I have given you a few examples in the last part of the day. And the key thing here is do not keep quiet, never keep quiet. After 5 seconds, 10 seconds, just start describing and say that I do not see any finding on the obvious findings, so I'm going to go through my protocol or whatever. And you start describing, lungs are clear, heart is this, hilum is this, trachea is this. And as you go, three things will happen. Number one, if you keep quiet, you will get very tense, your adrenaline gets secreted, and then you will lose your concentration and you will be terrified. And number two, when you, if you are describing your protocol, you are, what I say, thinking aloud. So the examiner is gaining something out of it and seeing your thought process. And even if you fail, the examiner might give you, let's say, 5.5. But if you keep quiet, the examiner might give you 4. That is the difference. And the third thing is that when you are going through your protocol and you say, I am looking at the bones, and the examiner might give you a hint. Okay, you have described the clavicle, can you have a second look? And there might be something in the clavicle. And final thing is that if the examiner gives you a hint, review the bone, review the soft tissues, or review X, or review the hilum, that is your last chance. So take the chance and now go into details and start describing it in details, giving yourself time. That's the key. So for example, it's bony thorax. You start saying that, I'm looking at the ribs, I'm comparing the right first rib with the left first rib, it's normal. I'm looking at the right sided other rib, second rib is normal, third is normal. Go into these details and you will pick up the finding. But don't panic. Keep talking and that will help you.